this computer. Okay, it's my pleasure to welcome Dr. Irwin Goldstein to our virtual summit today. Dr. Goldstein has been involved with sexual dysfunction research since the late 1970s. He's authored more than 350 publications, as well as multiple book chapters, and edited 6 textbooks in the field. His interests included penile, microvascular bypass surgery, surgery for dyspareunia, sexual health management post-cancer treatment, genital dysesthesia, persistent genital arousal disorder, physiologic investigation of sexual function in men and women, and diagnosis and treatment of sexual dysfunction in men and women. Dr. Goldstein is Director of Sexual Medicine at Alvarado Hospital, clinical professor of surgery at University of California, San Diego, and practices medicine at San Diego Sexual Medicine. He is also editor-in-chief of Sexual Medicine Reviews and past editor of the Journal of Sexual Medicine. He's a past president of the International Society of the Study of Women's Sexual Health and of the Sexual Medicine Society of North America. He holds a degree in engineering from Brown University and received his medical degree from McGill University. The World Association for Sexual Health Award, the gold medal to Dr. Goldstein, was awarded to Dr. Goldstein in 2009 in recognition of his lifelong contribution to this field. In 2012, he received the Ishwich Award for Distinguished Service in Women's Sexual Health. In 2013, he received the Lifetime Achievement Award for the Sexual Medicine SNA. And in 2014, he received the Lifetime Achievement Award for the International Society for Sexual Medicine. He's happily married to his college sweetheart, Sue, and together they have 3 children and 5 grandchildren. Does that sum it up pretty well?
Thank you, Matt.
That was a mouthful, a little bit. So really excited to have you on, Doc. You've done some groundbreaking clinical research in the study of men's and women's sexual health. It's been my my goal for the last 2 years since we started this podcast to have you on as a guest. So one more, Laura. Thank you.
Well, honor. Thank you.
Doc, so the way I look at this, I look at Tom Lieu out of University of California, San Francisco, who's pumping out 17 to 20 papers a year on animal studies on how this has been beneficial, the Softwave treatment and the Urigold, how it's been beneficial for sexual health. And again, he's doing the animal studies, and you have taken his studies and applied them in a clinical setting. So can you tell us how you connected with Softwave tissue regeneration technologies?
So Matt, first of all, thank you. It may have been your honor to get me on, and it's my honor back at you for being on with you. It's a privilege to share this information about Shockwave technology in the field of sexual medicine. It's really been a remarkable addition to our armamentarium. So getting back to my career, early in my career, back in the 1970s and 80s, we had an NIH funded laboratory to study especially men's sexual health. And we've been funded for 25 consecutive years on various topics in that area. And we established very early that the field of erectile dysfunction was really based on scarring of the erectile tissue within the anatomy of the penis. The 2 chambers are called the corpora cavernosa. And scarring was adversely affecting their function. The tissue, I'm going to use my hands here. You have the tissue in the penis, and in the normal healthy person, there's an artery that subserves the center part that blood rushes in. And blood drains from that erection tissue underneath the tunica albuginea, which is a capsule that surrounds all this erection tissue. And the veins are on the outside between the capsule and the edge of the tissue. So in a normal healthy person, as their sexual event occurs, they would relax and expand the tissue against the capsule, the tunica, and thereby compressing close the drainage. So the ability to expand during muscle relaxation associated with sexual stimulation was a paramount item in trapping the blood. Veno-occlusion occurred because the tissue was able to expand outward. If you can get that concept in mind, the reality of scarring due to aging, hypertension, high cholesterol, diabetes, all the metabolic syndrome nightmares, which resulted in apoptosis of the smooth muscle cell and conversion of smooth muscle to fibrocytes, i.e. connective tissue, it impacted negatively on the ability to expand. If you can't expand, you can't compress, close the outflow. And therefore energy of the artery bringing pressure into the penis would escape because you couldn't compress the outflow, because the tissue wouldn't expand. We identified this very early, and we have always sort of sought strategies to impact on the scarring. And we couldn't really impact, and it was sort of frustrating. 5 years ago or so, we started stem cell administrations to the tissue to address the scarring. We used platelet-rich plasma infusions to address the scarring. And then I met with Dornier back in the day, and they were sort of interested in working with us. And we did the first ever clinical trial in the US many years ago with Dornier. It was a phase 2 trial. And then I flew to Bethesda to meet with the FDA to expand it to a phase 3 trial. And we had multiple sites in a phase 3 clinical trial. And we lost the support of the parent company. Reasons unknown, but it was sort of an early death to the project. And it was the year 2019. It was in the glorious state of Georgia, in the famous city of Atlanta. I attend a meeting called the International Society for the Study of Women's Sexual Health, and there's John Warlick. And I go up to him and I say, okay, I don't really know your company that well. You must be the alternative Shockwave people. You're the ballistic. You fake this whole concept of real Shockwave. You have to be the acoustic. Why would you be here otherwise? And he sort of set me straight that he was the real Shockwave. And I didn't know much about the TRT group, but I read about him. He visited us in San Diego. Got this April 1st of all times, April Fool's Day. 2019, and ever since April 1st, 2019, so it's a little more than 2 years, we've been using the Eurogold, that's what we use, 100 from TRT, made in Germany under MTS, as our prime treatment for, our prime treatment for our field. Now, our field, we've identified many uses for shockwave therapy, but one of our prime strategies with John was to start with a double-blind, sham-controlled, active treatment clinical trial. We wanted to take the field of, we think it works, we know it works, here's our N of 10. We wanted to do it in a double-blind sham control trial. That's what we wanted to do. And we set that up early in our relationship with TRT. And John was extremely helpful in getting this going. Unfortunately, COVID struck a problem with recruitment, although I have to say today we're pretty much to the completion of that trial, at least in recruitment, and then we'll play that card and eventually analyze the data and get it out. Our job is to do this in a scientific way. We've grown the use of Shockwave for male sexual dysfunction, specifically for erectile dysfunction. Again, our effort is to get the blessed tissue able to expand more, and if we could populate it with activation of stem cells, with healthy smooth muscle cells that would be able to relax and therefore expand and lessen the density of the connective tissue, that would be amazing. So we have a very, very fancy, high resolution, high frequency ultrasound device in our practice. And that allows us to put the probe on the erect penile shaft. In other words, all of this is now done in the process of erection. So we have pharmacologic agents via needle that are injected into the penis, maximizing muscle relaxation. And then with sexual stimulation material, they get to full erection. Now, during the process of erection, we can put the probe with right on the penile shaft. And because it's a high resolution, high frequency ultrasound probe, we have amazing visualization in grayscale, black, white, and gray, of the erectile tissue homogeneity. So in healthy penises, the grayscale is basically all gray. In people who have disease, the traditional patient with erectile dysfunction, we see areas of hypoechoic areas. We call them Swiss cheese-like as our English language thing, but they're hypoechoic versus normoechoic versus hyperechoic. Hypo and hyperechoic are abnormal findings in a grayscale of a man with erectile dysfunction. And we would then provide a certain amount of treatments to this man in the erect state. We're talking of acoustic impedance here. If you have this narrow penis, maybe this size, flaccid, limited blood flow, you apply a shockwave to it, in general, the shockwave will just flow right through it. If you have an erect penis, full of blood, wide shaft, the shockwave will actually acoustically impede, stay in the erectile tissue, activate the stem cells. Lots of data from Tom Lieu about the activation of stem cells, with the idea that downstream cells such as smooth muscle will be made. And our ultrasound studies before and after treatments show a little more, 58%, will show improvement in erectile tissue homogeneity, thus validating the concept that we can, for the first time in history, impact positively on this negative finding of scarring or fibrosis within the erectile tissue. We can finally do something about it. And we correlate the grayscale improvement to the actual outcome of the patients who claim improved erectile function. So we have really impacted on the field of erectile function and dysfunction with real, genuine shockwave therapy, not the ballistic wave.
Yeah.
Let's take 2 seconds on ballistic waves. They're nowhere near the energy profile of a shockwave. A shockwave has a very high peak rise time in fractions of a microsecond, and then fall to below negative, and then come back to the baseline in 3 microseconds. Radioballistic pressure waves have nothing to do with that kind of form. And in fact, all the data from Tom Lieu is based on shockwave therapy. It's not based on ballistic pressure.
Right.
And the amazing value of the TRT Eurogold 100 is it has a parabolic reflector. It's non-focused. It's really cool. I mean, if you take the probe and put on an erect penile shaft, this is my erection here, and I'm putting it on there. Everywhere the probe is contacting the penis, the energy is the same everywhere we apply it. So it's not focused to one area. That makes no sense in an erect penis. Not a kidney stone. We want the energy to be along the entire contact zone.
When you talk about that high pressure, low pressure, I'll just show this picture. That's kind of that is the Softwave.
Wait, go back, show us again.
So this is the Softwave fingerprint.
Stop for a second, okay? On the x-axis, which is time, that whole thing is microsecond. I want the world to say that that's 10 to the minus 6 is a microsecond. That's 3 microseconds. That's 3 times 10 to the minus 6 seconds, okay? That is, that's as fast as I was able to generate.
Yes.
In my hand. And that's way different than a radioballistic pressure wave.
Right. And I just to, you made a great statement in one of your speeches this past year, I believe, in Ishwish. And you said there's a lot of doctors out there who think they're using Shockwave. Well, in fact, I'll let you take it. It's more of this, which is a sine wave. So it's more of that ballistic stylus that's creating, it's actually, it's damaging the tissue, and it's causing trauma, which is turns to cytotoxicity, which is then creates the angiogenesis. Our device causes no damage to the tissue. Is that correct?
So I would have to bow to the basic science to Tom Lieu, because first of all, we don't see tissue damage on our ultrasound, and we don't see worsening of erectile dysfunction, except in cases where there is ongoing hypertension, diabetes, high cholesterol, that sort of community where there's progression of disease. I think that it's not that I have data that radioballistic pressure waves damage. It's that the data that supports Shockwave in the treatment of erectile dysfunction is based on Shockwave. It's not based on acoustic waves that mimic or try to confuse the doctor and the public that they're getting Shockwave. They're getting an acoustic form wave that really isn't a Shockwave in general. And it goes under the name Gaines wave in general, but there are other versions of this.
Mm-hmm. Yeah, so some exciting stuff, and I believe it was March of 2019 that you were in Atlanta. The year before that, one of the International Urology Association meetings was in Lisbon or Portugal. I forget which one it was, but Dr. Tom Lieu spoke at that one and said that within 3 to 5 years, every urologist was going to have a Softwave tissue regeneration type of device, or their clinics will be antiquated and kind of. And I just love the way he placed, kind of made that prediction, because what are your thoughts on that?
Well, I mean, how would you explain this? In my experience, the conditions in sexual medicine, men and women, that we are finding benefit utilizing Softwave technology, the Eurogold 100 parabolic reflector, is growing. And specifically in the field of erectile dysfunction, specifically, we're now finding we apply it to the lumbosacral region in women who have lumbosacral disc disease and radiculopathy of sacrospinal nerve roots, causing what's called persistent genital arousal disorder. We're using it in men with acute pain in their penis following penile fracture. We're using it in women who are undergoing vestibulectomy surgery preoperatively to reduce their opioid need. And that's very exciting use. We are constantly identifying uses for the Shockwave. I have to gloat, okay, because we're about to present this abstract to another international meeting, but I had the disaster of placing a penile implant in a young man with erectile dysfunction. At around 4 weeks, he started spiking fevers and drainage of pus from his scrotum region, and he was sick, and I had to admit him to the hospital. And the standard of care for such patient is to apply IV antibiotics, make the person less ill, and then take the patient to the operating room to remove the infected foreign body. That is the standard of care. The patient was adamant against having another operation on his penis. He's already had several previous surgeries on his penis, and he said, there is no way I'm doing this. You need to try any and all conservative strategies before I'll agree to having surgery. Under that mandate, I felt justified to pick up the phone and call John Warlick of TRT, who explained to me that Shockwave has already been used in infected breast implants, in infected hip implants, and infected lines in left ventricular assist devices to quell the infection. So I brought up to the patient that we had a Shockwave machine. I had never used it before in an infected penile implant. I don't get many infected penile implants, which is the good news. But he agreed to his dream was to avoid yet another penile surgery. And he is, it was May 20th when he presented 2021 with the infection. We did the surgery way back in mid-April. And it is now June 7th, 2021, keeping you very up to date here. And he has essentially no more drainage of his penis. His white count is normal. He's feeling well. He has no pain and tenderness in the device. And we're on the verge of creating the first ever effectively treated penile implant infection with Shockwave and other strategies, including antibiotics. But I believe.
Could you see that being a future standard of care? Because that's what Piedmont Hospital.
So,
they
yeah,
just bought the second device.
Yeah, so I mean, so we place penile implants all the time. Penile implants are associated with pain in the penis postoperatively. Taking my data from the women having vestibulectomy, why is it that we couldn't provide shockwave therapy to men postoperatively, lessen their postoperative pain, or even provide it preoperatively to lessen their postoperative pain? Why can't we use it postoperatively to like prevent penile implant infection? And God only knows if there is an implant infection with the N of 1, not officially cured, but really close at this time in history, to use that. So now going back to Lisbon and Tom Lieu and this sort of bold statement that if you're in the field of sexual medicine, you will one day realize how important shockwave therapy is as a armamentarian to your overall treatment plans for all medical conditions in sexual medicine. It's very prophetic because one of the prime strategies for urologists in the field of sexual medicine is to place penile implants. That's what they have been tasked to do since 1973. It's, you know, we're working in almost 50 years now of that privilege. And to take a non-invasive strategy that better helps their patients in their post-operative care, pre-operative care, and God only knows if there is an infection, and salvage this process. It's another use for it. You know, you could interview me in 6 months and I'll probably have 4 more uses that I have tried.
That's no joke. John Warlick says that it seems like every 3 months we find a new condition that Softwave can help benefit. And it's not the main thing. We're utilizing a lot of different therapies with it, but it seems like it magnifies those other. And what
I have to interrupt you for 1 second.
Go ahead.
Before, when it was April 1st and John came to San Diego with his team, he had and still has a fabulous team. He took us out to dinner. And from my house to dinner was, let's say, almost a mile. And Sue and I walked there. Well, I played high school hockey, college hockey, high school football, post-college hockey, and on and on. And I have a left osteoarthritic hip. And I walked to the meeting with John in a hobbling sort of way. And John immediately started claiming that his device could help me with my hip. So it's now, again, 2.5 years or whatever with his product. And pretty much 2 to 3 times a month, I'm shocking my hip. Of course, along with my genital parts, because I know how successful this is. So I'm not only the guy who treats, but I'm the guy who gets treated.
You're the Sky Sperling of remember that guy, the Hair Club for Men?
There you go. So it is 2.5 years later. I still have avoided hip implant surgery. I get around very well. Sue and I walked to the zoo. We did many hours at the zoo, did several miles of walking there. I'm not like a perfect person with my hip, but I'm trying to avoid surgery, and let me broaden my use of it as an individual.
Exactly. And one of the things that why this has an antimicrobial and antibacterial effect, I'm going to show this up for our audience. And this shows the actual compression of the cell in that in the positive tensile part. And then there is expansion by 10% in that negative tensile force. And you say it so well. These supersonic sound waves are traveling 4.4 times the speed of sound, or 5 times the speed of sound. And those compression factors, those lipid membranes of bacteria and microbes cannot withstand the shearing force. Is that correct? Would you agree from the research?
Well, I have an N of 1 with infections, so it's been unbelievably successful so far in this N of 1. But I love your expansion direction concept with supersonic waves. Just to point out a cool piece of information, 767 miles an hour is the speed of sound, and that's in air. The speed of sound in water is 5 times that, so it's over 3,000 miles an hour. And the shockwave out of the TRT is coming out of water. So it is coming out of, each shock is coming out more than 3,000 miles an hour. That's just amazing.
That's yes, exactly. 3,355 miles an hour in that 3 to 4, you called it microseconds. So I could not have you on this show without talking about a very rare.
Without Sue.
Without Sue.
Sue is everything.
She helped set this up, and I'm grateful. She's your gatekeeper for sure.
Everything.
So without talking about PGAD, persistent genitalial arousal disorder, very rare disease, has a high rate of suicide associated with it. You've made a real impact, and I would love for you to chat a little bit about it. Please, you're the expert on it, so explain.
While it's rare, there's actually 1.6 million women who have this in the US, just alone, forgetting the rest of the world. It's rare, but it's primarily undiscussed because it's not something that you wish to share, even with your own partner, that you have this condition. So it's an unwanted, intrusive genital arousal that you can't ignore. And it happens without any sexual reason for this happening. There are there's probably more than 50 reasons for a woman having persistent genital arousal. By the way, men have persistent genital arousal also. And it gets even uglier in the men, because if they approach orgasm, they actually ejaculate, and there's a fluid problem that they have multiple times a day without their permission every day they're alive. It's a nightmare condition. We call it the monster. Of the 50 causes, one of them is pathology in your lower back. That region is called the cauda equina. Lumbosacral disc disease causes irritation of nerves in the cauda equina, nerve roots actually, and that's called radiculopathy. And that message ends up in the brain and is interpreted as that person having arousal. So the question is how to quell the radiculopathy in the sacrospinal nerve root in the lumbosacral region. The most obvious is to do surgery, but there are a group of people for whom surgery is not indicated or can't be done, or they just wish to not undergo spine surgery. So as my osteoarthritic hip has taken a hit by the shockwave therapy, if we could lessen the irritation through shockwave therapy applied to the lumbosacral region, we would have a treatment. Well, guess what? Since we see a lot of patients with PGAD, PGAD, and we've done this now on a number of women whose PGAD is remarkably better controlled through the use of shockwave therapy. So yet another indication.
And by the way, originally you started treating the genitals and they would get short-term relief, maybe an hour or two. But then John was like, check that lumbo, I'm sorry,
lower back area.
Yeah. And it was seemed like you went 5 for 5 with wonderful results. And I remember that's when I met you in March of 2020 at Ishwich in Orlando. And you actually had a couple patients that were there and testimonials, but I think you're 15 for 15 or 15 for 17 at this point.
We have a high rate of success in highly selected patients. It doesn't work if you had 50 reasons for PGAD, 49 of them have nothing to do with the use of shockwave therapy. For that highly selected patient whose pathology is really based on lumbosacral disc disease, the utilization of shockwave therapy to lessen the irritation has proven to be beneficial to that select group of patients.
That's great.
But at the end of the day, truth be told, surgery probably is more valuable. It's a long-term cure for this population. And what we have found is that, let's say they have a PGAD bother scale of 10 out of 10, just ridiculously overwhelming their lives with constant arousal from their genitalia. And surgery can be highly successful, but in some patients, it doesn't go to a 0. Their 10 out of 10 goes to a 3 out of 10, and they're just remarkably thankful for the improvement. But some of them will call me up and say, okay, thank the surgeon so much for this thing, but is there any way to get rid of that last 3 out of 10? So that's when we'll yet another indication, post-operative spine surgery, to get the patient to as less bother from this condition. So we have a bunch of those patients who are undergoing shockwave therapy with really nice success, bringing their 3 to a 0 or 1 successfully.
And again, it's about creating realistic goals for your patients during that care plan. For us, and I've given you a little insight about our alternative non-invasive type pain center here in Atlanta. It's ATL Pain Institute. The average patient that walks through our door walks in with a VAS score of 8. And typically after 5 visits, we have them down to a 3.5. Awesome. And we've got 4 years of data on that. And I mean, again, we're not getting rid of all their pain, but it's now manageable and they don't necessarily have to take strong narcotics or anti-inflammatories as much. And they're able to cut down on those injections.
So we have physical therapists in our office. We're a biopsychosocial multidisciplinary unit. We have nurse practitioners, we have sex therapists, a biology-based person, myself, and our physical therapists. So a patient with erectile dysfunction who is a runner and has a knee problem or an ankle problem or a shoulder problem or a hip problem, our physical therapist will work with them with the Eurogold 100, typically on weekends because we're using the device primarily, or evenings when we use it.
That's great that you're taking a whole body approach to it. We're coming close to the end of this, so I want to chat a little bit. There's so much research in the cardiac field. You made a statement in one of your talks that the NIH has a lot of research towards the cardiology because it's such a major killer. The one thing that I thought from the research that is just overwhelming is the recruitment of endothelial progenitor cells and how those are the repairmen of our intervascular system. Can you just talk about, because you're on top of this research much more than I am and any other practitioner. Can you give us a little insight on that?
Well, let's argue that the penis and the heart share a lot of common issues. They're both organs that require blood flow and depend on excellent blood flow for their health. And things that go wrong with the heart, heart attacks and strokes, are based on atherosclerotic vascular disease, and their risk factors are diabetes, hypertension, high cholesterol, throw in depression, which is another risk factor for a heart attack, are the exact same risk factors for erectile dysfunction, hypertension, high cholesterol, diabetes. You could argue we're sort of the early warning group that, you know, the cavernosal artery in the penis is 1 millimeter. The heart artery, the coronary artery, is 3 to 4 millimeters. So if it's going to happen as an atherosclerotic process, first is the penis. And the penis is very interesting. It's very sensitive to changes in pressure. If you don't have good blood flow to your penis, you will know it because your erection won't be as hard. It won't be as long elastic. So it's one of the early warning signs, the canary in the coal mine sort of deal. So you'll have ED, and a few years later, you're then going to get your heart attack and stroke. So the fact of the matter is they're highly related tissues, and the research that goes on under NIH and the cardiovascular institutes that shows shockwave therapy is helping hearts restore function after a heart attack is the same stuff that we're trying to show with the grayscale ultrasound that we talked about at the beginning of this interview. It's a strategy to rejuvenate vascular tissues, to lessen their scarring and the adverse effect of scar on the function of that tissue. It's very parallel. And it's really fascinating that there is now a basis for this coming from the cardiovascular group, but let's apply it to the heart easily.
And the rest of the body. I was so grateful for you. You presented in Nashville, and I forget what year, I think it was 2019, the end of 2019. And you showed some of the great work that Dr. John Mullins had done.
Yes.
And even though it was a bunch of urologists from around the country, they were still awed. And this is the study of one of our patients that Dr. Mullins and I got to work on. He was a diabetic neuropathy patient. He walked around with a piece of glass in his foot for 10 days. And Dr. Mullins was able to debrief that. And we treated him weekly for 8 weeks, once a week for 8 weeks, about 2,000 soft waves. This was 2 weeks after. And you could see, I mean, I almost could fit my finger into that area in the first picture. And that second one, which is 2 weeks later, this is activation of connective tissue. This is the body repairing that wound. And he never bled, even when he debriefed it, until the third week that we did the treatment. And you can see it right there. So it was pretty wild. I believe this is going to help thousands of patients avoid amputations as we get this more out to trauma centers and wound centers across the country. Any thoughts before we?
So I have a diabetic male with a penile implant who fell asleep lying flush on his penile implant that was erected, probably used it that night and fell asleep after 6. And he developed an ulcer on the penile shaft as a result of the lack of blood flow from the pressure. And it was very concerning to us that it would erode to the penile implant. So yet again, another new treatment for wounds and penile issues in men with sexual dysfunction. We shockwaved, we did twice a week, but maybe we think the penis is more important than the foot, I don't know. We did twice a week shockwave treatment, and we completely healed his penile ulcer. And I've done a series of wounds that have happened to penis that we have used shockwave therapy to help heal those wounds. So I didn't even remember this indication, but we share with you.
Yes.
Dr. Mullins is one of my favorite human beings on earth. And
he really is.
Really
he's been on our
amazing.
show 3 times now, and he's coming on for the virtual summit.
So please say hi to him.
I will. That was the final picture. Unfortunately, that patient was also on dialysis and passed, but he had a will to live because he wanted to prove that this would help. Dr. Goldstein, really a pleasure. Thank you for all the work you're doing, and God bless you and Sue for really bringing this to the forefront in urology and this therapy as an elective tool. And really grateful to have you on, and look forward to meeting you in person out in San Diego the next time we're out there.
Thank you, but let me thank back to John Warlick, the TRT team, for having this equipment, because it's one thing to do the research, it's another thing to have the equipment to do the research. And I want to thank not only all the people at TRT, I want to thank Ernest, because at TRT, the flipping over of the probes is just so critical, and he is so wonderful at helping us through all this. So a shout out to Ernest for
You're absolutely Stuart and Stuart
amazing
Floyd as
person
well.
he is.
Yeah, Ernest Pringle, those two are the heart and soul of this company. And you're right. I thank them every time I walk into that building because of the work they're doing. And yeah, you're
Actually,
right.
you know what
John,
Ernest just did?
no.
Because of the gentleman who had the penile implant infection, I wanted him to shockwave the penile implant with 100,000 shocks at maximum energy to see if it actually hurt the device. So he just finished that. He's mailing it back to me. I'm going to test the device, but we're going to show that Shockwave doesn't injure the device, I hope, allowing us to use Shockwave in people who have the device.
On all implants. I have something I'll be sending you. I've got the Orthogol 100 Model S that has 500 shockwaves in it. And so we're finishing up. Yes, you're the next to get it. I was the first in the country, but you will, it'll find a place out in San
I'll take second place to you anytime to get a 500,000 probe.
That is really the future of this technology, and so excited. And thanks to John Warlick and Mark Gronowski for keeping this dream alive. Part of this virtual summit will tell the story how literally 3 years ago, we were almost not here. So you'll get to see the full virtual summit coming up, Doc. And thank you for being one of our keynote speakers. Really a pleasure. Have a wonderful rest of the day.
Thank you. Have a good one. Thank you. Bye-bye.